Good evening and good afternoon, wherever you are in the world. Thank you for being here. And we are on to the third module of the Uro Oncology certification course. And today we are discussing a very enigmatic condition called upper tract urothelial cancer. Now, some of you may recognize these individuals. Those who don't, this is Alfred Blalock on the left side of the screen. And the lady is Helen Tusick and Vivian Thomas. Now, you may remember that the two gentlemen and the lady are responsible for the BTT shunt. Now, BTT shunt, as you know, is the operation for the blue babies. Now, why am I showing this cardiothoracic surgical innovation in a urological meeting? Is because our main hero, Dr. Blalock, Alfred Blalock, was a heavy smoker. He was a professor at Johns Hopkins, and while making a presentation, he collapsed on the stage and was ultimately diagnosed to have an upper tract urothelial cancer from which he succumbed. We are very fortunate today that we have the world-class speakers for today's session. And I'm going to briefly introduce the speakers. Dr. Khurram Siddiqui, Senior Consultant Urologist at Sultan Qaboos University in Oman. We have Professor Pilar Laguna. She doesn't require any introduction, opinion leader not only in Europe, but across the globe in Uro Oncology. Dr. Pankaj Maheshwari, who is a senior consultant in Maharashtra, India. And Professor Abirane, who is a college registrar and associate director of the Royal College of Physicians and Surgeons, Glasgow. And they are all recognized figures around the world, and they can give you real insight about this enigmatic condition. Unfortunately, Dr. Rane is in a transit at the moment. So he sent me his presentation, which I'm going to run. He won't be able to join in person. So I'll share his presentation.
It's a pleasure to participate in this certificate course. In Uro Oncology, organized by the Aga Khan University. Sorry, I can't be with you in person due to pre-existing commitment. I have no disclosures. Let's talk about upper tract urothelial cancer. And when we talk about UTUC, we look at the entire length of the ureter, starting from the pelvic calyceal system all the way down the length of the ureter and including the intramural ureter. It's very important to consider this when we look at how we're going to manage this tumor. These are the images that many of you have seen variations of and fairly typical of upper tract urothelial cancer. How common is UTUC? Well, it's actually not that common. It's a tumor that involves only about 5% of the total number of urothelial tumors that we see. Urothelial tumors aren't as common as renal pelvic tumors, and the peak incidence appears to be in the 7th decade. The worrying thing about UTUC is that about 50 to 60% are invasive at diagnosis. Now, if you contrast that with bladder tumors, it's about 10% or 12%, sometimes up to 20%, but certainly no more than that. It seems to seed, if that is the right word, about 15 to 50% of tumors will recur in the bladder. The risk naturally is higher with CIS or multifocal urothelial tumors in the upper tracts. You turn that on its head, and it's only about a 2%, maybe 3% risk for developing upper tract urothelial cancer if you have a diagnosis of bladder cancer in a patient. What are the risk factors? Well, I've listed them there. The common one is tobacco. And the other thing that I was quite interested in seeing was coffee on that list. I was much relieved to find out that you had to drink more than 7 cups a day for several years to increase your risk of upper tract urothelial cancer. This is the TNM classification, fairly straightforward. How do we diagnose upper tract urothelial cancer? Well, it's generally by a CT urogram, or for those patients with impaired renal function, sometimes we go for magnetic resonance urography, retrograde studies. Flexible ureteroscopy remains the mainstay of getting tissue diagnosis. Can get cytology and brush biopsies. And we can, in fact, look at something that was considered quite taboo until recently, and that's percutaneous biopsy. These are two papers. They're probably about 7 or 8 years apart. And they basically look at the option of percutaneous biopsy for TCC of the upper urinary tract. They seem to conclude that the risk isn't higher just by taking needle biopsies. There certainly doesn't seem to be any tract seeding, which is interesting. Still hasn't taken on, and I don't know of very many centers that do it regularly. However, it is an option if needed. What are the prognostic factors? Well, you can see there are a number of them, but I think the one that is the one that we can influence is by getting the surgery done as quickly as possible. So anybody with who has to wait has a poorer outcome. This is the risk stratification into low and high risk, and I won't read through it, but it just goes to show how different it is, and certainly the tumor size seems to be very important as compared to what it was considered to be earlier. What is the pathology generally? It's transitional cell cancer. It's a few variants of squamous metaplasia and very rarely adenocarcinoma. Where do you find it? Well, as I had alluded to earlier, renal pelvic tumors seem to be commoner. Most of the ureteric tumors appear to be in the distal ureter. And sometimes you have synchronous tumors both in the renal pelvis and ureter, about 5 to 7%. Interestingly, the data that has been pooled and analyzed suggests that you can get between 2 and 5% of bilateral presentation. How does it spread? As one would expect, it is cephalotocodad, and we've talked about the risk of developing bladder cancer, following upper tract urothelial cancer, and that's a risk that varies between 30 to 70% or so. We've touched on this earlier, but the only thing I didn't mention there was CIS, where the risk is as high as 25%. How do we manage upper tract urothelial cancer? Well, one tends to adopt a kidney-sparing approach. Flexible ureterovenoscopy and laser ablation with the biopsies is what most people practice. There is the ability to offer percutaneous treatment via a nephrostomy. One can excise a segment of the ureter with the TCC in it. Finally, there is a school of thought that has kind of used the installation of BCG or mitomycin to help manage the tumors in the ureter, particularly those which aren't particularly high grade. Obviously, high-risk tumors are a different kettle of fish. The reference standard remains a radical nephroureterectomy with a bladder cuff excision. There's some debate about whether a lymph node dissection should be included as standard. You can do this either open laparoscopically or even more commonly now robotically. And I think the literature is getting more mature regarding robotic nephroureterectomies as replacing the reference standard open nephroureterectomies. The management of distal ureter still is a topic that has been debated. There are a number of approaches to it. The most common one in the past was the plug technique. One can strip the ureter down, do a TUR of the distal ureter, and intercept it into the bladder, and then resect it. There are variations on the theme, but I still think that the large bladder cuff excision is probably the safest way of dealing with the lower end of the ureter. There's a study which was published by the team at Guy's about 13 or 14 years ago, which shows the advantage of a single dose of mitomycin on the day of catheter removal. And finally, if there is any suspicion of invasion, the recommendation is to consider neoadjuvant chemo. It's very important because once you remove the kidney with the tumor in it, then the GFR falls, and that kind of impacts on their eligibility to have post-operative chemotherapy. So this is the treatment flow chart. Many of you would have seen it in the EAU guidelines, and well, we won't go through it, but it's quite clear and quite self-explanatory. It kind of encapsulates what we've just talked about over the last 5 or 7 minutes or so. The evidence is interesting. The one thing that came out to be quite strong, which I hadn't really envisaged it to be, was that if you presume somebody has muscle-invasive cancer, either by the appearances or sometimes by getting a tissue diagnosis, the evidence is quite strong to perform a template-based lymphadenectomy in those patients at the time of the radical nephroureterectomy. This is the follow-up, and it's kind of depends on where you work and what the protocols are locally. There aren't really any strong level evidence indicators which corroborates what the recommendations currently stand at. However, it just does give you an algorithm to base the follow-up protocols on. This was a very interesting paper from Ricardo Otorino's group, which basically looked at all of the guidelines out there and about how to manage upper tract urothelial cancer. And you can see the AUA has a slightly different take on the management as compared to the EAU, and the National Cancer Network guidelines are slightly different as well. You can see the differences in management and how we follow up these cancers. Each organization has its own algorithm. I think what Ricardo's group has stated is very important in that we need to consider upper tract urothelial cancer as an entity per se, with its own diagnosis, management, and follow-up strategies. And naturally, we need more high-quality research to create a better consensus. So in conclusion, I would state that transitional cell cancer of the bladder and upper tract urothelial cancer are two separate identities. They are not variations of a theme. The differences are quite clear. The embryological origin of urothelial cancer is different to that. That arises from the bladder because they arrive from different areas. One from the mesonephros, the other from the cloaca. There are biological and molecular differences between the two tumors. And finally, the management is very different depending on the site of the urothelial carcinoma. Thank you very much for your attention, the opportunity to participate. And I'd like to thank Professor Arthur of the Aga Khan University, PAUS, and the Sark Association of Urology for the opportunity to participate in this course. Thank you.
Thank you very much, Professor Rani. And I think Abhay has very clearly and provided a generic background, an overview of the upper tract urothelial cancer. From there on, we are going to have three presentations. First by Dr. Maheshwari, and who's going to talk about the low-risk cancer. Dr. Maheshwari, the screen is yours. In the meantime, Dr. Maheshwari is loading his slides. Please feel free to post your questions on the chat box. And if you wish to ask a question in person, please wait for the end of the presentation and we'll have hopefully an opportunity to address these questions to our faculty. Pankaj, you are muted.
Yes, now that's better.
Yeah.
Sorry, I was struggling. I sincerely thank you for this opportunity. And is my slide visible? Is my slide visible?
Yes, sir.
Yes, Pankaj, they are visible.
And it is visible in full screen?
Yes.
Okay. So I sincerely thank you for this opportunity, and it's indeed a honor for me to be part of your certificate course. I have been asked to talk about low-grade UTUC, and Dr. Rane has indeed made my job easy by giving an overview of this topic. It has been told to you that this is a rare malignancy, though we commonly see bladder cancers, and the incidence of bladder cancers, especially in Southeast Asia, is steadily rising, but we do not see UTUC so commonly. UTUC is known to be related to smoking, radiation, chemical exposure, and also hereditary in form of Lyme syndrome. Among the urothelial cancers, UTUC forms a very, very small subgroup, probably less than 5 to 10%. And most of these would be seen in kidney and around 1/4 in the ureter. The treatment definitely is based on the grade and the location of the tumor. We all know that the grade of any disease, or especially malignancy, that is an important factor that links to the aggressiveness of the tumor, the invasiveness of the tumor, and the metastatic potential. And definitely UTUC is definitely UTUC also follows the same principles. How can we predict the grade? We can predict the grade by looking at the size and number of the tumors. The smaller the tumor, solitary tumor are likely to be low grade. Multiple large tumors are likely to be high grade. A tumor which is papillary is likely to be low grade. A sessile or a flat lesion is likely to be high grade. And if there is associated hydronephrosis, that would mean that the tumor has probably gone into the mural component of the ureter. And that is why it probably is an invasive tumor and a high grade tumor. Cytology is a very important differentiator. We will come to this later in the presentation. The significance of grade is shown in this paper, where they have followed the patients over 7 years, and they have found that with increasing grade of the disease, the overall risk in the disease steadily increases. Even the treatment is based on the grade of the tumor. Low grade tumors, you could do a nephron sparing approach. High grade tumors definitely needs a more aggressive treatment. We need to understand here that UTUC is an extremely aggressive disease, and uh, properly stratifying the patient for correct treatment is very important. If we try to do a nephron sparing surgery in a patient who has a high risk disease, this patient may have a very poor outlook in long run. So accurate assessment of grade is extreme key to management and treatment planning. We would add all these things together and divide the disease into low risk and high risk. So a unifocal small tumor, low grade cytology, low grade histopathology, no hydronephrosis would be considered as low risk, and associated hydronephrosis, large tumor, multifocal tumor, high grade cytology or high grade biopsy will be considered as high risk. Low risk can be, this criteria were further made stringent by NCCN when they reduced the size criteria from 2 centimeters to 1.5 centimeters and insisted that for a favorable clinical pathological criteria, the tumor should have low-grade pathology on both cytology and on biopsy. Low-grade disease can be treated by endoscopic management, by nephron-sparing treatment, and high-risk disease would need a radical nephrectomy with lymph node dissection and with probably chemotherapy in a neoadjuvant setting. There would be some situations with solitary kidney, associated CKD, or a patient who is not willing for radical nephrectomy, where endoscopic treatment could be done for a high-risk disease. Now, why we are trying to do a nephron-sparing treatment? As a urologist, we would definitely want to spare kidney whenever and wherever possible and safe. We know that radical nephrectomy has significant amount of perioperative complications. Whether you do by open or robotic, the perioperative complications range to the tune of 8 to 20%. And there is definite reduction in kidney function when you knock out one kidney of this patient. As it is, these patients are likely to be older, may have associated diseases like blood pressure and diabetes, which can have associated renal insufficiency. The obstruction by UTUC itself would reduce the renal function, and hence these patients are likely to have CKD at the time of diagnosis, and the renal function would worsen once you do a nephrectomy. Once you do a nephrectomy and patient lands in CKD, the overall prognosis reduces, perioperative morbidity increases, cardiovascular morbidity and mortality increases, and you will not be able to give nephrotoxic chemotherapy to this patient in future. There are various nephron sparing strategies available. We will discuss them in details. Now, once a patient comes to you with a suspicion of UTUC, a proper cross-sectional imaging, cystoscopy, diagnostic ureteroscopy, and cytology would be extremely important. CT scan is definitely the imaging of choice with a sensitivity and specificity beyond 90%. It will not be very good for staging and grading accuracy. It may miss flat lesions and CA in situ. And wherever there is a suspicious lesion on CT scan, you would definitely need to do a ureteroscopy to confirm your diagnosis. MRI would be done in patients where contrast cannot be given. So patients who have associated low renal function, raised creatinine, MRI could help, though the overall specificity and sensitivity of MRI is lower than CT scan. Contrast enhanced ultrasonography is an upcoming modality for diagnosis. It is definitely better than grayscale sonography. It can differentiate between high grade and low grade tumor because it can detect the blood flow in the tumor. And the overall size estimation is better with contrast enhanced ultrasonography. Cytology is the mainstay. We grade the cytology as per PARIS system. PARIS system, as you know, depends on the atypia, associated hyperchromia, coarse chromatin, irregular chromatin rim, and then how much number of cells are show these characters. So based on this, you would decide whether it's a negative for cytology, suspicious, or a high grade. One thing we need to understand here that cytology positive can happen in all grades of tumor. If you have a biopsy which is low grade and cytology which is positive, the question would be, how do we treat this patient? Remember that if there is a low grade biopsy and high grade cytology, this patient should be treated as high grade because it is possible that there may be a misrepresentation in your biopsy. Cytology positive, in all probability, this patient has a high grade disease. If there is a voided cytology is abnormal and patient has a filling defect, then you could do, apart from routine cytology, ureteral catheterization, washing, or brush biopsy. Do they correlate with the overall histopathology? Yes, voided cytology may be unreliable in high-grade UTUC. Direct sampling improves the yield of cytology. And if there is a high-grade cytology, that is sufficient to establish the grade of the lesion. Newer tests like FISH, fluorescent in situ hybridization, are there. They detect the aneuploidy in the cells which are there in the urine. The AU guidelines suggest that the sensitivity is around 50%. The clinical place of these tests is yet to be decided. Many new markers are being tried. Among this, DNA methylation is one test which is coming up in a good way. It has a very good sensitivity in voided urine. The sensitivity for high-grade TCC is very high, to the tune of 97%. And it can also detect patients with low-grade UTUC. If the DNA methylation is positive, these are patients who are likely to have worse prognosis and would need aggressive treatment on their follow-up. Where would we place endourology? Endourology would be used for evaluation of hematuria, filling defects, and suspected tumors. We would do disease mapping by endourology. We will get histopathology diagnosis and definitely management wherever feasible. We need to differentiate between diagnostic and therapeutic endoscopy. Not every patient who has a UTUC would need therapeutic endoscopy. It is important to differentiate between these two because a diagnostic endoscopy would need a shorter time. Not every patient who has a UTUC would need laser fulguration or laser excision of the tumor. If on your biopsy it turns out to be high-grade disease, then further endoscopic treatment is not needed and this patient goes for a radical nephrectomy. So diagnostic will be done to visualize, map, get a cytology and biopsy. So basically to diagnose the disease, and therapeutic would be done to either ablate or resect the disease. So basically to treat the disease. When you are doing a ureteroscopy, it is extremely important to have a standard reporting checklist. And you should write in details where exactly the tumor is, what is the appearance, number of tumor, size of the tumor. This would be important when you do a follow-up scopy, because to see how much is the response to your treatment and which are the sites where there is recurrence, this standardized checklist reporting would go a long way. If a patient comes with hematuria where there is suspected tumor, that means CT scan has not picked up a tumor and you want to see for the source of hematuria or source of positive cytology, then the way do you do cystoscopy would be slightly different. Initial detailed cystourethropy would be important. When you do a upper tract endoscopy, try to minimize use of wires. Definitely do not use dilators, access sheath. Contrast should be instilled only once you have taken sample for cytology. Instilling contrast before cytology sample would hamper your yield of cytology. Uh, the lower and mid ureter can be assessed by a rigid ureteroscope. And if you find a tumor like this, then you could use a cytology or a biopsy to diagnose this tumor. Various different ways of biopsies have been described. The most important way and a successful way would be to do a biopsy by basket. When you use a basket, the basket would sling the tumor. You would be able to get on the stalk of the tumor or get under the tumor, and then a large chunk of the biopsy can be collected with a basket. When you are taking a biopsy from the kidney, it will be important to pull the biopsy specimen towards you. But when you are taking a biopsy from the ureter, don't try to pull the biopsy towards you. Rather, once you hold it in the Dormia basket, go upwards towards the kidney so that you don't pull the ureter towards you and traumatize the ureter. Again, whenever a biopsy is done, it should always be done through access sheath. We do not want the biopsy to come through the normal ureter and the bladder and take a risk of cell implantation. A recent study which compared which is better, basket or forceps. The forceps biopsies were much smaller. The yield of forceps biopsy was much lower. So definitely in today's time, the way to do a biopsy would be to buy a Dormia basket. Biopsy has a limitation. You may miss high-grade disease in the biopsy, but overall, with biopsy and cytology, you will be able to grade your tumor well and take a decision about further treatment. How can we improve the biopsy? You could use PDD or narrowband imaging. These will help in visualization of small flat tumors. Endoluminal ultrasonography or confocal laser endomicroscopy is a good way. When you are doing biopsy, if it's a papillary tumor, basket. If it's a flat sessile tumor, a cold cup biopsy would be needed. Cryobiopsy is coming up in a big way. Cryobiopsy is regularly used in pulmonary scopies where ice ball is created at the lesion. The lesion tends to stick to this ice ball, and then getting this without really damaging the cell architecture becomes easy. Is it always needed? If the patient has visible hematuria, a solid lesion, and a strong history of smoking, almost always this is UTUC, and probably in these patients, you could go ahead with definitive treatment based on other factors on CT scan. Endoscopic treatment would be the way for low-grade disease. Both antegrade and retrograde approaches have been described. We could use all type of energy sources, electrocautery, holmium laser. These days, TFL is extensively being used. Whenever we are doing ureteroscopy, a proper diagnostic cystoscopy and a reassessment of cross-sectional imaging is important. Biopsy of the tumor and documentation of the details of tumor, extremely important. If you find associated lower tract disease, then that can be resected in the same session, but you should still take biopsy of both bladder as well as the upper tract. If access is difficult or entry into ureter is difficult, then a gentle dilatation or a chronic dilatation by a degestant could be done. If access is not possible, then upper tract washing or barbotage can be done. Definitely, if you have lesions seen on one side, do not try to assess the other side just to confirm that that side is normal. That is not needed. And once you have the biopsy, then a proper histopathological testing, including IHC and microsatellite instability, should be assessed. Once biopsy confirms that it's a low-grade disease, if it's a small tumor, just laser fulguration can be done. Laser fulguration use the least possible energy and a high frequency. Gradually, just keep on fulgurating tumor from superficial to deep. At this low energy and frequency, you get a very good ablation and good hemostasis, and small and even superficial tumors can be very easily managed by this. Which laser should be used? Initially, Nd:YAG laser was described. Today, it is hardly ever used. Holmium and TFL both can be used. TFL has an advantage because the fiber is very small and it will be easy for you to get into the lower calyx with the TFL laser fiber. This is one patient we had done. Left side nephrorectomy was done for UTUC. This patient came with significant hydronephrosis and a large solid looking tumor in the mid-ureter. Option of doing radical nephrorectomy on this side and planning the patient for transplant later on was discussed with the patient. Patient was not keen on that. So a laser excision was done. Now, when you do the laser excision, it is very important to try and get under the tumor. So push the tumor towards the kidney, get under the tumor, and then excise the connection between the tumor and the ureteric wall. Once the tumor is completely off, the base of the tumor can be fulgurated with laser, a stent would be placed, and then this patient would be kept on regular follow-up. So here the tumor has been excised, the tumor is being removed by a Dormia basket, and in the end, laser fulguration of the tumor site would be done. Another patient, a very interesting patient, we diagnosed this as a stone. We had noticed that the ureteric wall was looking very thick. When we went in, we saw these fronded lesions. It was not clear whether this is TCC or not. So stone fragmentation was done. At the end of stone fragmentation, a biopsy was taken from this site. Interestingly, this biopsy turned out to be a low-grade UTUC. At the time of stent removal, when we rechecked this patient, there was no residual disease. This patient has been on follow-up for nearly a year now. First-year CT scan and urine cytology has been negative. So at the end of excision of the tumor, a good fulguration by laser would take care of any residual disease there. When there are large lesions, especially in renal pelvis and lower calyx, where going with the flexible scope would be difficult, percutaneous access can be used. Make a tract which is around 24 French, go through a calyx which is far away from the site where the tumor is. Through a 24 French, you can put in your regular resectoscope, TURP resectoscope, and then excise the tumor both by cold cut and by electrocautery. So this was a patient, though the opposite kidney was normal, she had a large tumor. If you can see here, there is no ureteric or renal pelvic thickening. This patient was absolutely not keen on radical nephrectomy. We went through the upper calyx. Both cold cut and electrocautery cut was done. It is very easy to remove the tumor with a cold cut. At the end, major bleeders could be coagulated by electrocautery, and the base of the tumor would be fulgurated by laser. This patient has undergone a 3-monthly cystoscopy, which has shown no residual tumor at the end of 3 months. So at the end of this procedure, a stent was placed and this patient had a smooth postoperative course. A very large study of nearly 140 patients with 30-year experience. The recurrence happens in around 1/3 patients. Around 1 in 7 patients would need a radical nephrectomy on follow-up. Low-grade disease do very well. Overall survival more than 10 years. High-grade disease would need a more stringent follow-up. Again, for low-grade disease, whether you do nephron-sparing surgery or radical nephrectomy, the overall long-term results in form of cancer-specific survival and overall survival are comparable. This is the AUA risk stratification, where we can see that when there is a favorable low-risk disease, ablative treatment is preferred. Unfavorable low-risk disease, unfavorable meaning patient has multifocal tumor or may have associated bladder tumor. Here, ablative treatment may be offered. Even for favorable high risk in selected patient, you may offer nephron-sparing procedures. So a tumor ablation should be the initial management for low-grade favorable and may be offered for low-grade unfavorable or high-grade favorable disease. A long-term follow-up of nearly 15 years where endoscopic treatment was compared to radical nephrectomy. Overall survival at the end of 15 years was comparable in both the arms. Again, a large study where patients were analyzed based on the grade of disease, and it was seen that patients with low-grade disease, the disease-specific survival was to the tune of 98%. Again, these patients definitely need a regular follow-up because there is a theoretical risk of recurrence both after ureteroscopy and percutaneous access. Meta-analysis of nearly 950 patients who were treated both by NDI, holmium, and TFL laser. Average follow-up of 4 years. Recurrence happened in 20 to 90%, but average would come to around 33%. Overall, less than 20% needed radical nephrectomy. For low-grade disease, overall survival was more than 10 years. High-grade disease was to the tune of 5 years. Recurrences can happen anywhere. There could be recurrences in the bladder, in the upper tract, or patient may even progress to have metastasis to lymph node or distant metastasis. So a stringent follow-up of these patients is very important. And whenever and wherever the recurrences happen, they would need to be treated on merit. To prevent recurrence, intraluminal therapy has been tried. Intraluminal therapy is done by 3 techniques. One simple way is to try and see whether reflux can happen through a digestant. If you plan for this, though this is not an advisable way of doing it, then a pre-cystogram should be done with patient in Trendelenburg position. Confirm that adequate reflux happens, and then you could attempt this, though we should know that nearly 2/5 of the patient, there would be absent reflux, or reflux may not happen every time when you try a installation. So could be done, but definitely not a way or not an advisable way. Percutaneous installation is a very good way, but the problem would be that patient would need a nephrostomy tube, and not many patients would be keen on keeping a nephrostomy tube for a period of 6 weeks, because you would definitely do an installation once a week for a minimum period of 6 weeks. Placement of ureteric catheter and doing it through ureteric catheter is possible. The precaution should be that this should be done at a very low pressure. High pressures would carry a risk of, say, pyelolymphatic and pyelovenous backflow could increase the risk of sepsis. All types of intraluminal therapy has been described: BCG, mitomycin, interferon. Overall, the recurrence rates are low, but they are still comparable to patients who were not treated by intraluminal therapy. The problem with intraluminal therapy is that the environment is overall not friendly. What I mean by this is there is no way that the injected drug would stay for an adequate time, and the contact time may not be adequate. To take care of this, gel mito is one new treatment which has come up. This is a reverse thermogel treatment where mitomycin is to the dose of 4 mg per ml. Once injected in the body at body temperature, this solidifies, and this stays in body for 4 to 6 hours. This needs to be repeated weekly for 6 weeks. Overall response rate is more than 56% complete response rate at 1 year. The major complication that was seen was ureteric strictures. Now this can be avoided by giving gel mito through a percutaneous tube. One major drawback from our point of view would be an extreme cost. The cost of gel mito full therapy in Indian currency would cost nearly 1.2 crore rupees. Can it be used as an adjuvant treatment after endoscopic treatment? There are reports of this being used as an adjuvant treatment, but the long-term follow-up does not show adequate benefit with this. One option of doing a nephron sparing procedure would be by doing a segmental ureterectomy. Whenever the disease is limited to the ureter and the disease segment is shorter than 2 centimeters, then segmental ureterectomy can be done. The added advantage would be that with the segmental ureterectomy, you could also do a lymph node dissection. If it is in the upper ureter or mid ureter, after a ureterectomy, end-to-end anastomosis can be done. For lower ureter, you could do a cuff excision and then do a ureteric ring implant. Does this preserve renal function? The literature is not very clear in this. There are reports of all 3 types of changes in renal function: no change, reduction, or improvement. All 3 have been described. after segmental uretectomy. But the overall cancer-specific outcomes are comparable to radical nephrectomy in selected patients. Can this be done when the lesion is more than 2 centimeters? Yes. Then you would not be able to do end-to-end anastomosis. Then you could use a bowel segment as an interposition graft. Patient needs to be on proper follow-up. The follow-up would need CT scan, cystoscopy and cytology, and also repeat ureteroscopy. Every department would have their own follow-up schedule. AU has recently come up with a schedule depending on the risk stratification. Repeat scopy is definitely needed at 3 months and 6 months, and once at 1 year. And beyond that, patient would be followed by cystoscopies, cross-sectional imaging, and cytology. And whenever these things come positive, you would reassess the patient and then do a repeat upper tract surveillance. What are the newer things which are coming up? Because CT scan and biopsy has its discrepancy, so there is enhanced endoscopy can be used. We can use NBI photodynamic therapy to improve detection. There is a new technology which has come up, which is called as a multiparametric endoscopy, where all 6 modes are combined in a single monitor, and then it gives you a final image of the probable tumor. Robot-assisted ureteroscopy can be done with the assistance of robot. Having proper control on the laser fiber is possible. Prolonged procedure can be done. There are drug-eluting stents which can be kept in ureter, and they would give a sustained release of anti-cancer drugs over 4 weeks. And we could do genetic studies in these patients, which will help us identify high-grade disease, which probably would not be good candidates for nephron-sparing procedures. So finally, before I sign off, I would say that we need to personalize the management of UTUC, look into patient variables and tumor characteristics, and decide the right treatment for the right patient. So any patient, irrespective of the site of the lesion, if it's a low-risk disease, nephron sparing can be done. If it's a high-risk disease, then most often radical nephrectomy would be the way to go. I thank you for a patient hearing.
Thank you very much, Dr. Pankaj. It was very comprehensive, and you have covered almost all areas of management of low-risk, low-grade cancers. Now we move on to perhaps one of the most aggressive of all urological cancer, which is a high-grade upper urothelial cancer. And we are very fortunate today that we have Professor Pilar Laguna, opinion leader in this area, to take up this important subject. Dr. Laguna, the floor is yours.
Thank you. Thank you, Professor Ater. Well, I would say that after the magistral lesson of colleague Maheshwari, there is not a lot of things that I can do, but I hope that I can drive you and all of the attendees on the pitfalls in the diagnostic of the high grade and why it's important and why we have not yet dilucidate the problem between the high and the low grade. I don't have any disclosure, and I would like to start saying that the importance of making the diagnosis of high grade is because stage and grade, wherever it is, are the main prognostic factors in overall survival, in cancer-specific survival, and in recurrence-free survival. High grade is associated with advanced pathological stage, with non-confined disease, and local, regional, and distal recurrence. And most important, grade is the first factor to categorize non-metastatic UTUC according to the risk of progression of non-confined disease. The risk of progression categorization is capital in the treatment decision making. Let me see, here the next one. And the first thing that I would like to you has already been commented by the previous speaker is how are we going to grade this UTUC? And we move from the 1973 classification in grade 1, grade 2, grade 3 to low and high grade. And if you see in the bars figure on the right, you see here, this is a series with with more than 4,000 UTUCs treated by radical nephrectomy. You have very few grade 1. There is, of course, there is a bias in all the series. The whole body of literature practically is retrospective, but you can see here in low grade, the bars in yellow or in orange is the low grade and the high grade. And you see that once you use all classifications, still what we were thinking that was a grade 1 in 10% of the cases is a high grade. This increases when the diagnostic of our pathology is grade 2, and practically all grade 3 is high grade. So be careful, because once the literature has to be interpreted, you have to look which kind of classification has been used. Wait a minute, because this is not. The prevalence, grade, and stage. This is probably the largest series, more or less contemporary, comes from the United States, and you see that high grade in this series was found in almost 75%, almost 2/3 of the cases, low grade in 18%, and unknown grade, still you will have cases of unknown grade in 13%. Important also is to be aware of the variants, what we were calling variants, which is called subtypes since 2022, and to think that the majority of the ureteral cancers of the UTUCs are urothelial tumors, infiltrating or not, grade, low grade, high grade. But there are a lot of subtypes who have been diagnosed in the last years that may account for 23-25% in the series, and the 2022 classification added the large nested and the tubular. This is important because once you have a high risk, once you have one of these variants, one of these subtypes, automatically the patient becomes high risk. And in some of these variants, your pathologist will not be able to tell you that this is a high grade or if this is a low grade. So by definition, all of them are associated to high pathological, infiltrating pathological stage, and you can, different types of these variants, subtypes, can concur in a single tumor. The most frequent of these variants of these subtypes is the squamous divergent differentiation, but you have others that are sarcomatoid, which is relatively frequent, 6%, glandular, micropapillary. Those are the most important. Please consider this as a high-grade, high-risk tumor automatically, if that may change your treatment. Treatment in all the major guidelines is based on risk stratification. Let me read what is risk stratification. More or less has been said by the two previous speakers, but at the time of identifying the UTUC, clinicians should perform a standardized assessment documenting clinically meaningful endoscopy, focality, including focality, location, appearance and size, and radiographic invasion, obstruction, and the presence or the absence of lymphadenectomies. All these features will facilitate the clinical staging and risk assessment. So it is not one test or another. It's a composite of tests, which difficults the things, which is gonna stratify the patient in low or high risk. They are different, as it has already been pointed, in a different way, and is cytology, of course, is the this slide has already been shown, I think, 2 times in these presentations, but I would like to tell you or to communicate. This is new in the guidelines 2024. I suppose it's going to be repeated in 2024, but for the first time, the European guidelines recognize that some of the criteria who should be make the tumor high risk UCT are weak criteria, and this is highly reflects in the American classification, the recommendations of the AAU, no, sorry, recommendations of the AUA and the Society of Uro Oncology. And as you can see here, cytology, imaging, and ureterorenoscopy in those cases are just making from a high risk, but unfavorable, and from a low risk, from a low risk and unfavorable, and from a high risk favorable. So this is this intermediate category that is still very ill defined, and that we should strive to make this to make the differentiation. I'm moving these things here like this. The NCC guidelines, they have two different recommendations depending if the tumor is localized in the renal pelvis or in the ureter. What about all these prediction models in the preoperative staging? Well, the only thing that I can tell you is that they have a relative acceptable accuracy, all of them, between 70 and 79%, but histology, non-histology, in the preoperative setting is included in most of these models. And histology, the only way to the only way to get histology is by means of ureterorenoscopy or biopsy. I'm not going to say that it's a mortal sin to operate a patient or to do a nephroureterectomy without ureterorenoscopy of biopsy, because you can have cases in which it's indicated, but we should strive to do ureterorenoscopy and biopsy in most of the patients with indication of a UTUC. The recommendations of the AAU, of the AUA, and of the NCC these three recommendations include the use of the diagnostic URS if imaging and voided urocytology are not sufficient for the diagnosis and or the risk stratifications. The Americans, they are much more strict than the Europeans in the recommendation, and the NCCN cytology, URS, and biopsy. So American seems to be one step further with us. Only if the ureteroscopy cannot be performed or is not possible for whatever reason, you may try selective or a barbotage, a washing of the upper urinary tract. And if, for whatever reason, some of those patients are already in renal insufficiency, they cannot have a CT or they cannot have an MRI, then the best that you can do, if there is suspicion, to do a pieloureterography and also barbotage of the tumor. Indeed, it has been already pointed, the introduction of the digital image and the minimization of the instruments and the profusion of basket, they have been facilitating. And I would say that URS is not the most difficult test or the most difficult procedure for a patient in which you may need to take a kidney. It is important. Checklists already recommended by the AUA mean all the factors, all the variables that you have to note in your checklist. Is a little bit more complicated than the one that we use for the bladder cancer, but all of them gives you additional information in a certain moment that may be important. You have biopsy, and the biopsy, the only way to get the biopsy is if you have been doing a ureterorenoscopy, and clinical versus pathological grade. So the problem is the concordance or the agreement between the low grade and the high grade. And you see here, and this is quite a good paper with more than 1,000 nephroureterectomies patients who have been biopsying, that and the standard for comparison has been the specimen, the surgical specimen, that when the biopsy tells you that there is a low grade, only 37% of the patients are going to have a low grade in the nephroureterectomy. So majority, 2/3 of the patients are going to be upgraded. And so is so in total. And if you look for the pitfalls when they tell you that is high grade, it can also be downgraded, but up to all of them, especially, and if the biopsy is unclear, you will see that around 42% of the patients may be upgraded at the radical nephroureterectomy. We published recently some data from the CRUISE, and the conclusions of our paper was that the endoscopic biopsy grade significantly associated with the final pathology grade that we already knew from all publications, but the concordance agreement of low-grade endoscopic biopsy with the nephroureterectomy specimen is around 67%, and once you have high grade, then this concordance, this agreement is almost 100%, 95%. This is one of the best, if not the, this is one, is a very good one, if not the best of all the multiple systematic reviews that we have around the UTUC. Again, the data is retrospective, but you can see here that these authors go for the clinical grade to the pathological grade. A lot of quite a number of papers, and again for the clinical low grade 66% of agreement. For the clinical high grade, the agreement is almost 100%. And the positive predictive value, if you find in the biopsy or your pathology tells you that this is a high grade, then you may have muscle invasive disease in 60% of the cases. And on the other side of the spectrum, the negative predictive value for the clinical low grade and non-muscle invasive disease was 70%. But this is the negative predictive value. Undergrading, that means higher grade surgical specimen in 32% of the cases at least. Pitfalls, and the reason why there is undergrading, or you may have insufficient sample in around 8%. In real life, it can be even higher than this, and this you have to audit your data to see how good you are in this. The previous colleague told us that definitely you have to go for the biopsy, the basket biopsy. You can do very good basket biopsies, but not all the tumors are to be sampled by a basket biopsy. Even not all the tumors can be sampled by by forceps. So if you go for ureteroscopy, please do also selective urine cytology of this renal unit. You can have a sampling error, biopsy what should not have been biopsy, difficulties in sampling muscle, already known, false positive after instrumentation, misinterpretation, interobserver variability, and most important, you can have tumor heterogeneity, and you can just biopsy the low grade, and this tumor also has cells who are high grade. If you look for the correlation between the correlation of the biopsy between the clinical and pathological stage, again, same stage in clinical TA, etc. It's very low. Clinical T1, the concordance is also low. This is quite an old series, retrospective, but it's still very valid. And so overall, upstage found in almost 60% of the cases between the biopsy, between the clinical stage and the pathological state. So we cannot really stage the tumors by ureteral biopsy. Here is also data from the CRUISE, but you see that once you say that the tumor, when you find a tumor that is low grade, well, you can have quite a good concordance with the final pathology stage, almost in 40% of those tumors are going to be, I think that this red should be down, but anyhow, is the high grade the one which is just giving you a good concordance with the final pathology, with more than 60% of these tumors that you have a biopsy high grade being T2 or T3. And if you include, and some authors include the T1 into the invasive tumor, then you go up to the 70%. Again, with the stage problems in the stage, we are able to stage tumors who are TA, but we can not even stage the T1 and, of course, T2 and T3, but there are very few tumors in the series of the CRUISE we were staging them. Low-grade biopsy predicted PTA disease in 35% of the cases, and PT1, which theoretically are the ones who are not invasive. This is terrible. Those in 58, almost 60% of the cases. High-grade biopsies predicted, considering PT carcinoma in situ as high risk, or more than PT2 or PT2 in 70% of the cases. Again, from that systematic review, clinical stage to pathological stage, positive predictive value for clinical T1 muscle invasive disease, very high, and negative predictive value for clinical TA or TIS of 60%. Remember, this I could not understand why they include the the carcinoma in situ as non-muscle invasive. It's not muscle invasive, but is a high risk category. Under staging in 46, almost in 50% of the cases, just like tossing a coin into the air. Major pitfall in the stage, of course, is the difficulty of sampling muscle because of the risk of perforation. The layer, the muscular layer in the ureter is really, really thin and tiny. Cytology in the diagnostic of UTUC is highly dependent on how you are collecting this cytology. Voided urine is not sensitive enough and has a very high rate of negative, false negatives. Selective urine, the sensitivity improves, and especially if you go for the grades, and especially for the high grade, and compare it with the biopsy, has a sensitivity of 53% and specificity very high of 90%. And barbotate cytology, if you really are doing it well and washing all the renal cavities, then you may detect almost 91% of the cases, but that's not what is done in most of the cases. So I would say, do not do voided urine, go for the selective urine, and if possible, a barbotage. My colleague has already been talking about the PARIS cytology, the seven categories, and it seems that to apply the system, the PARIS system, increases the sensitivity and balances with the specificity, which is very, very, very high. It doubles in some papers the surgical concordance from 34 to 60 something, and overall shift toward downgrading diagnosis for other authors. Even some of them decrease, report some decrease in sensitivity. I don't know how you do this. Let me see. I don't know how to do this. Yeah, now, a combination of biopsy and cytology. In high grade, sensitivity of cytology is comparable to the ureterorhinoscopic biopsy, one on the side, one on the left. But the combination of both results in sensitivities up to 85%, 86%, which is very high. And the added value is highly dependent on what's the performance of both tests in your institution. So you have to know if your cytologist, because is a specialization of histology, is providing you with a high sensitive and high specific results. The mode of collection of the sample, remember, better selective or barbotage. The standard for comparison, in some papers, they compare the cytology or the combination of cytology with the URS biopsy, or if you are comparing with the definitive specimen. And the diagnostic system who's been using to grade the cytology. And overall, think that if the bladder cancer, if there is inter-observer and intra-observer variability in bladder cancer, this is known, is very well documented. This may also occur even at a higher level in the upper urinary tract. Cytology and ancillary urine tests. Dr. Maheshwari has been already talking about this. We do have a lot of biomarkers, but the only thing which really has been tested so far is the FISH. And FISH has a higher sensitivity than the cytology and also a higher specificity, and especially positive predictive value and negative predictive value are very good. Problem, of course, is the cost, the availability, and the generalizability of the test. In any case, complementary, the ancillary urine tests are complementary and may be useful, especially to reduce invasive follow-up. Just I'm finishing with a couple of slides, and I would like to present you a model who has been just devised quite recently. As already said, a lot of factors, or there are a lot of variables, a lot of factors who are really significant and who are associated with invasive higher stages, and also with non-organ confined disease. Age at diagnosis, high-grade cytology, high-grade biopsy, sessile architecture, presence of hydronephrosis, and the presence of a very advanced tumor in imaging or lymph node, all of them. And if you put all these factors together, then you have an area under the curve of 0.77, which is no more and no less than the same data that I've been showing you in the beginning, all 10, 15, even more years old predictive models. But what the authors did, and that was smart, we have much more knowledge of statistics right now, they were for a technique which is called the Youden index, and that is, with this you maximize the sensitivity of, or the sensitivity of each one of these variables, and from a single variable 1, single variable 2, single variable 3, you may do a composite, which in fact is what we need for these tumors. And with this, they may offer a solution to this overlap between unfavorable low-risk tumors and favorable high-risk tumors. And as you can see here, if you have 1, 2, 3, 4, 5 variables who include the size, cytology, which is negative, low grade in URS, biopsy, unifocal disease, no invasive aspect on imaging, the probabilities, the estimated probability that this patient has a PT2 or more is really, really, really low. If the patient, of course, has one of the following factors, and those are the same ones who are just described in the American guidelines or in the European guidelines, then the estimated probability is 0.49, and the odds ratio for a muscle invasive is almost 5-fold times the one of the low risk. But there is this intermediate group, intermediate risk group, which we should aim to identify, because if we treat these patients with nephroureterectomy, we may be doing an over treatment, and if we treat these patients with a low risk, we have the risk of under-treated this patient. I would like to finish the presentation with just a review coming from Taiwan, and is on the inter-observer variabilities. In fact, this is an original paper done in the registry, in the Taiwanese registry for UTUC, and all the slides that were used for the initial diagnostic, they are nephroureterectomy specimens. All the slides that were used for the initial diagnosis were reviewed by a pathologist, a central pathologist who was blinded for the initial pathology. There were differences in this central review in practically all of the variables, all of the factors that we as urologists are going to use for treating this patient: in grade, in tumor architecture, in invasiveness, in histology, in the presence of a histology variant, in the T stage, in the presence of lymphovascular invasion, and in the perineural invasion, and even on the surgical margins, although that was, of course, the lower one. And you can see in the graphic in the right side that the ones who were really decisive were the P, T stage, and the configuration. So those are the ones in which the magnitude of this difference was more prominent. Take-home messages. High grade is a prognostic factor and capital factor in risk categorization and in treatment choice. The WHO 2004-2016 is recommended for grading, and the Paris system for cytology assessment. All variants and divergent pathology should be considered high risk. Histology by URS biopsy or cytology are recommended in the diagnostic pathway in all major guidelines, and it should be like this. In comparison of the nephroureterectomy pathology with the URS biopsy shows that in 1/3 of the cases we are undergrading, and in 46% of the cases we are understaging this tumor. Accuracy of models predicting invasive disease varies between 70 and 79%, suggesting unmet needs for improving diagnostic and risk stratification, which may or may not come from the somatic mutations determinations. It is, remember, is a very rare disease and condition. I thank you very much for all your attention, and I'm going to see if I can go out of this and
Thank you very much, Dr. Laguna. A very lucid and comprehensive talk on this enigmatic condition. There must be some questions, and I think these questions are being posted. So if you have the opportunity to kindly address these questions in the chat box, and if there are more questions in the end, we will take it after the end of this webinar.
Thank you.
Thank you very much. To wrap up today's session, we have Dr. Khurram Siddiqui, who is going to talk about some of the contemporary issues of upper tract urothelial cancer. I think we had 3 wonderful talks so far, which have literally covered most of the areas. And Khurram is going to address some of the surgical aspects and some of the controversies in the management of particularly the high-grade disease. So, Khurram, the screen is yours. You are muted, Uro. Can you unmute yourself, please?
Okay, can you hear me now? Yeah?
Yeah. Yes, we can.
Can you see my screen as well?
Yeah, we can see if you can go into this presentation mode, we can see the whole screen.
Just a second, it's just telling me to upgrade.
So if you go into the slideshow and go into the full screen.
Yeah, I'm trying to. Is it okay now?
Yeah,
Yeah?
perfect. Thank you.
Oh, perfect. This one, too. Okay. My job is really made easy by the kind of, knowledgeable and eloquent speakers before me. And really all the knowledge transfer which had to be done as the core kind of, knowledge for our fellows who are joining us is almost done. I would kind of, use this opportunity to emphasize on some of the previously described points and kind of, add a few practical points to kind of, whatever has been already described in detail. And so, what are the goals of treatment in upper tract urothelial carcinoma? Of course, the first major goal or the primary goal is in any oncological cancer is oncological control. And here, we are dividing the patients into high risk and low risk. And why are we doing that so carefully is not to miss on the oncological control. See, so there are secondary goals, of course, which are kind of, preservation of organs and minimal morbidity. And as kind of, elucidated before, radical nephrourectomy historically has been the standard of care. However, it is associated with certain morbidity. And before we could kind of, win on the oncological control with any other organ preservation approach, we all kind of, took it for granted that, whatever morbidity of the radical nephrourectomy be, this is the only thing which as a surgeon we can do to help our patients. And kind of, we all of us bite that bullet and offered nephrourectomy to our patients. However, this was at the cost of their renal function and cardiovascular morbidity. We know from previous speakers that there is a reduction in GFR as a long-term after a nephrourectomy, and there is kind of, associated morbidity with lower GFR as well. Additionally, there is cardiovascular abnormality, the risk of acute myocardial infarctions and other related cardiovascular events increase after, somebody who has a poor GFR and has a solitary kidney. Now, previously, we have discussed in detail about the different diagnostic modalities which are used in diagnosing and staging this disease. So just to summarize, I am not adding anything to whatever has been described before. There are two main issues when we are dealing with upper tract transitional cell carcinoma, and these issues are related to the radiology, which kind of looks at the sensitivity of accurately kind of staging the disease and then selecting an appropriate patient who we are able to offer a treatment with minimal morbidity and control his disease effectively for a long period of time. We rely on radiology and pathology in this regard. Now, when we are doing radiology has improved over a period of time for our patients, and it's important that when we have a patient who is we suspect that there is an upper tract transitional cell carcinoma, be it because of gross hematuria in absence of any infection, or there is kind of positive cytology, and we are asking for a CT scan. It has to be for the students in our group. Has to be a 3-phase CT scan. scan, with a plain film, a nephrogenic phase, which is done after 90 seconds, and then an excretory phase, which is about at 10 to 15 minutes interval. And all these images have to be acquired as thin sections, and these sections have to be reviewed very carefully with the radiologist. Now, radiology, as Dr. Laguna was talking, and I was looking at the risk factors which kind of, increase the chances of having high-risk disease. Radiologically, and a higher T disease has a very high odds ratio of predicting an aggressive disease. Here, in the ureteric pathology, if you see that there is carefully on a thin scan, you magnify that image on a sitting with the radiologist, and we all know that the computers which we use in our kind of daily practice are kind of they don't have that many pixels as the computers which are kind of there in our radiology suite. So my advice is to always go to the radiology and review these images with the radiologist, because not that there is anything wrong in your kind of diagnostic ability, but just the fact that those monitors are much higher definition than our workstations in the wards or in the floors. They are not able to kind of see those minute details which are very critically important in predicting the stage of the disease, and then subsequently the kind of outcome of the patient. So if you have a speculated output, or you have a solid ureter, that kind of raises a suspicion that you may not be dealing with a disease which is amenable for an organ sparing approach. These are probably patients who you should consider as patients for nephroureterectomies and subsequent adjuvant treatment. I will not go into this, is the older slide. So as far as pathology is concerned, for a low-grade pathology, we used to consider as grade of cytology is probably equal to the stage in most of the cases. But however, if you have a higher grade pathology, higher grade cytology, the chances of upstaging the disease or a higher stage disease are much higher, as elucidated by Professor before me. Now, just a few tips about the biopsy, and I think Dr. Maheshwari has explained that, if you are in the ureter, and most of us are using now, there are no longer kind of, forceps biopsies. Most of the biopsies are done with the help of the baskets. And when you are in the ureter, you know that this point, the uretero-pelvic junction is a fixed point. And if you pull below, then your chances of damaging the ureter are quite high. So in the ureter, in the kidney, you can do whatever. You can go up, down, right, left. It doesn't really matter. You can get as much tissue as you want to. But if you're in the ureter, then better to kind of push the ureter upwards, and then kind of unplug the specimen, and then kind of come back. And of course, all of us do use access sheath, and it's very important to protect the entire urothelium with this free floating cells as much as we can when we are withdrawing our specimen. I got this picture from somewhere, but in my practice, I have never seen such a kind of easy ureter in which you can kind of walk up and do a TUR there. As Dr. Maheshwari has also shown that pressure, intrarenal pressure, is very important. It's very important for our stone ureteroscopies as well, and as well as for in cancer case when we are dealing with. And there no circumstance we should allow the pressure to be high, like in 90 centimeters of water. And the other one point which I also like to mention here regarding the barbotage is that when you are doing a barbotage, you should use a smaller syringe. Somehow if you use a 10 cc syringe or a 20 cc syringe, the amount of pressure which you can kind of generate intrarenally with a big syringe without kind of appreciating it on your digital is quite significant. So use smaller syringes for barbotage, like a 3 cc, 5 cc syringe. However, for prevention of primary bleeding as well as vision inside, always try to kind of, keep the pressure at around 80 centimeters of water. Now, what has made upper tract urothelial carcinoma an organ-preserving disease is the advancements in radiology. So by exclusion, if you do not have a high-grade disease, the disease is small, the advancements in radiology, the advancements in our endoscopic units, and the maneuverability which we have made it possible for us to offer organ-preserving approach, organ-preserving solution for upper tract urothelial carcinoma for our patients. But there are certain situations where, we kind of, want to do that. These are different scopes which are used. Now, what are those problems when we are dealing with somebody who has, when somebody has upper tract transitional cell carcinoma? I will not go into the details about the oncological control. Just one meta-analysis in which, in a properly selected patients, the low risk upper urothelial cancer, kidney preservation can achieve as good cancer control rate as nephroureterectomy. But this preservation should only be offered to a patient where we can ensure that their lifelong and follow-up is possible. Because as any other urothelial disease, which we know from the bladder, is there are two problems. The problem is recurrence and the problem is progression. So how do we kind of, deal with these two issues? There is a high risk. There is, even in low-grade disease, there is a 30% risk. Previous presenters have elaborated, and then there is a kind of, risk of not catching that in time or timely catching the disease, and even not able to rescue it with endoscopic maneuvers, and you would have to kind of, resort to salvage nephroureterectomy, which in low-grade disease is a lower chance. In high-grade disease, more than 1/3 of the patients will progress and kind of, despite whatever we do, and the risk of salvage nephroureterectomy is always there. Now, to minimize the risk, people have kind of, as in bladder tumor, we emphasize on regular surveillance cystoscopies. And here, there are two modalities with which, we can do survey. It is not as easy as the bladder, where we know we only kind of, don't have to think twice and kind of, book the patient for an office cystoscopy. Here, the two modalities of imaging with the CT urography and with ureteroscopy, both are present. And the guidelines are quite, variable with the use of ureteroscopy and urography, and depends on the healthcare system. It depends on the expertise. And I would just like to kind of, leave you with this a little 2 minutes pondering on this follow-up schedule, and what our guru in endourology for upper tract, Dr. Trexler, he is quite an enthusiast with the surveillance with endoscopy, and his endoscopic schedule is quite intense on endoscopic surveillance, which he kind of, in the early, in the first 24 hours and first 24 months is literally at 3 months interval for the first 6 months, and then 6 monthly for another 24 months. And then after that, he is on the annual one. However, practically speaking, for most of the patients, this may become unaffordable or may not be that possible. And the guidelines from the Europe recommend a combination of initial follow-up with ureteroscopy, followed by a more intense radiological follow-up. Now, another thing which we are kind of, quite familiar with is the use of adjuvant immunotherapy, chemotherapy for prevention of recurrence, and both BCG and mitomycin have been used in this regard. And there is no prospective study, but retrospectively, there are certain there is literature which suggests some positive role for it, although there is no hard evidence in this regard. However, the problem here is again the delivery, and Dr. Maheshwari elucidated that to deliver adequate amount of BCG to the entire urothelium in the upper tract, it is not easy kind of ordeal. It's a challenge. All of us kind of want to rely on the double J stent and give immunotherapy and rely on the reflux, which may or may not be present. However, I'll show you in the later slides that there is a nice study which shows that which method is probably the best theoretically. Chemoablation by Jelmyto has been discussed in detail, so I will not go into the much detail with this. But of course, there is a kind of significant risk of urethral stenosis with this treatment. However, in upper tract urothelial cancer, sometimes you are not able to completely treat the disease, and in this case also, in this series also, there was a significant patients population where the tumor was not reachable by laser, and in this study which was presented by the company, they found that even if you're not able to completely eradicate the disease by laser fulguration, chemoablation with Jelmyto will take care of some microscopic disease. However, there is a financial toxicity of this, which was elaborated by Dr. Maheshwari before. Now, this study is a very nice cadaveric study in which the three forms of delivery of the adjuvant treatment were studied. And what they did was that they put some methylene blue through the nephrostomy tube, through the pigtail catheter, and through the ureteral catheter. And if you look at the staining of the ureter with the nephrostomy, surprisingly, the kidney is stained quite well. But for the ureteral, the ureter here, it is hardly any staining here. So, our kind of, notion that if we have a pigtail catheter, we will be able to utilize the physiological kind of, mechanism of the peristalsis of urine, and we'll be able to kind of, coat all the urothelium with the adequate amount of drug so that it can take its effect and produce the desired effect of reduced recurrence, may not be kind of so easily reproducible. And in pigtail catheter, you see that it is slightly less than the nephrostomy. However, there is a better kind of staining of the ureter in this slide. The best form is with the urethral catheter, and with the urethral catheter, single J coming out, chemotherapy given or immunotherapy BCG given through this route has the highest chance of kind of highest chance of having adequate exposure to the urothelium. But this is probably practically the most difficult, challenging modality. Then there is another in development stent, not very widely available, which the stent itself kind of releases over a period of time chemotherapy agent. And in the slides you can see on experimental effect of this of the cytotoxic effect of these drugs, which is quite kind of interesting development if it comes through. So these were the issues, and these were the things which we want to preserve. If we want to preserve the organ, the issue is of accurate staging. We rely on heavily on the cytology, and when we are debating a cytology and pathology, of course, cytology, whatever is higher risk, then takes precedence, and you want to manage the patient as a higher risk if whatever cytology or biopsy upgrades it, or even radiology, whatever upgrades it. In the management of high-risk disease, there is a very important role of management of bladder cuff, and the role of lymphadenectomy is kind of coming up stronger and stronger, and is more established as previously. When we are managing the distal ureter as endoscopic, we all of us are kind of well versed with endoscopic techniques. In this, their one methodology is to kind of, core out the ureter and then pull it up. The other one is to kind of, core it out, then put a stent, and then tie the stent when you are doing the open part of it, and pull it out. All the methods are kind of, valid methods. However, the standard care is to kind of, mobilize the ureter as low as possible, and then to take a generous cuff. Now, when we are taking these generous cuffs of the thing, the most important thing is kind of, to be aware that there is another ureter sitting very close to this one, and sometimes the trigone, we know, can be very narrow. And in that case, it is very important that we kind of, although we want to get as much of the bladder cuff as possible, but we should kind of, avoid morbidity to the other ureter. A way to avoid this is by making a cystostomy. Now, I've seen older my teachers do this, but it is kind of, this method is falling out of vogue, especially with the coming evidence that, post-adjuvant single installation of chemotherapy significantly reduces the risk of subsequent recurrences in the bladder. This kind of, increases the theoretical risk of kind of, denying that opportunity to the patient. So the other thing which was discussed earlier is the role and extent of lymphadenectomy. These are kind of, our knowledge from the anatomical cadaveric studies which are done. And for minimum lymphadenectomy for a T2 disease for upper tract, on the right side, the template is shown. On the left side, the template is shown again. I don't want to kind of, take your much time here, but in the right side, paracaval and interaortocaval up to the level of the bifurcation for a renal and upper ureteric lesion, and on the left side, you go para-aortic and intra-aortocaval there. And for the distal or the middle ureteric, you don't need to go up into the hilum of the kidney. For a distal ureterectomy, you kind of, go around the ureter on the paracaval lymph nodes on the right side, and the para-aortic lymph nodes on the left side. So just to conclude and to kind of, summarize all what has been said, organ preservation approach is a safe alternative with equal outcomes. And the most important thing after the pathological concern is that we should ensure that, the patient which we are offering this treatment is ready to comply with a lifelong intense radiological as well as endourological follow-up. The elective indications and the imperative indications have been described. Recurrence and progression can be reduced by stringent follow-up, use of intracavitary installation of chemotherapy and immunotherapy. Future outcome can be improved by these drug-eluting biodegradable stents and by chemoablative agents like Jelmyto. In high-risk disease, the nephroureterectomy remains the standard of care with careful distal ureterectomy to prevent difficult resection in case of recurrences. Lymphadenectomy not only provides useful information regarding staging, but can, in limited disease, can be potentially curative. And for younger patients who present with this disease, molecular testing is very important, and especially markers for other syndromes like Lynch syndrome are to be considered. Thank you very much. And I would just like to invite you to our Oman Urology meeting, which will be in the November 13th to 15th. This time it will be in Muscat in collaboration with the Arab Association of Urology. All of you are welcome to attend. Thank you very much.
Thank you very much, Khurram, for covering up all the gaps in the previous presentations and to supplement the knowledge on upper tract urothelial cancer. I think we had some wonderful session today. We have slightly exceeded time, but that's fine. So I don't see any further questions. Thank you very much. And just to remind you that next in a fortnight's time, our next session will be on neoadjuvant and adjuvant chemotherapy by Professor Pilar Laguna. And then we have few very interesting cases which will be presented, and so that we have an interactive discussion on these cases and apply the knowledge that we have gained from today and from the next session. This will be followed by the post-module test, which will be 15 to 20 questions, and you will receive this course hopefully in a week's time. So thank you very much, and a very good evening. See you again in a fortnight's time on 15th of February for the next webinar on upper tract urothelial cancer.
Thank you very much.